Okay, final one, Chapter 30, Psychosocial Needs of the Older Adult. The older adult. So after age 85, there is a 1 in 3 chance of developing dementia, immobility, incontinence, or other age-related disabilities. You'll see below here that we have the young old, which is categorized as 65 through 74 years, middle old, which is 75 to 84 years old, which is 85 to 100, and then elite old are also known as centenarians. That's 100 plus years, and they actually have super centenarians. That's 110 plus. So anyway, that's kind of just your overview as what the categories we have for those that are older adults. Mental health issues related to aging. Depression is not a normal part of aging, but does account for 70% of late life suicides. Depression and suicide risk, white males older than age 75 at the highest risk. Risk factors include access to weapons, access to lethal doses of medication, chronic or terminal illness. And then protective factors, so things that are involved or part of the person's life that can actually decrease the percentage or possibility of suicide would be religious beliefs, spirituality, perception of social family support, and having children. So these different things are actually protective factors that will decrease their risk of depression and suicide. Anxiety disorders, hard to diagnose in the elderly. One unique anxiety is fear of falling and can lead to agoraphobia. Agoraphobia is the fear of basically being out in open places. So you end up having people that you'll call maybe a shut-in, somebody who doesn't really leave their house or is afraid to leave their house, but that's agoraphobia. Typically those who suffer with that stay in their house pretty much all the time. Anxiety is twice as prevalent as dementia and 8 times more common as major depressive disorders. So anxiety is a huge thing for our older population. SSRIs are a good treatment for the elderly, so that's your selective serotonin reuptake inhibitors. What that means, in case anybody doesn't know, all of our SSRIs prevent serotonin from being taken up in the receptors that they typically are taken up in, so that actually leaves more out for the body and the brain to use. And we will learn more about that when we get to our medication chapter. But SSRIs are things like Prozac, Zoloft, there's some others, Celexa, that they end up making it so the patient has more serotonin available, which is a feel good, and you'll hear me use that term a lot as we get further in. Benzodiazepines, these are things like Xanax, Ativan, Valium, are frequently used and overprescribed. These are anti-anxiety medications. Should be used cautiously. Side effects include confusion, oversedation, increased risk for falls, and this class of medication also has increased abuse potential. So at Brighton, you guys won't be there, but for the ones who end up there, and for me, we actually do a ton of benzodiazepine withdrawal, which is very similar to alcohol withdrawal. Mental health issues continued, delirium, dementia, alcohol abuse. So alcohol abuse tends to decline with age. Late onset alcohol abuse is often related to environmental factors and may include retirement, widowhood, and loneliness. So retirement, widowhood, and loneliness can all cause a depression, and then some that were not ever abusers of alcohol before may begin to try to numb out and feel or not have to feel. Often hard for practitioners to recognize. One reason for this is it's underreported. There's such a stigma around people who drink too much. and or use substance in order to cope that they underreport or they don't report at all to their doctor. But symptoms of alcohol abuse in the older population may include confusion, malnutrition, self-neglect, weight loss, decreased functional status, diarrhea, or urinary incontinence. And this last one, it says there is evidence that older adults respond better than younger to treatment. I know you can't see all that, and then I wrote next to that true, and that is very true in my own professional work, that the older adults we take care of in Brighton actually do tend to respond much better than our younger population. So moving on to pain, up to 85% of older population is thought to have conditions that predispose them to pain. However, pain is not a normal part of aging. So if you see that, know that pain is not a normal part of aging. Pain can lead to increased stress, delayed healing, decreased mobility, disturbances in sleep, decreased appetite, agitation, and aggressive behaviors. And there is mounting evidence that treatment of pain improves mood. Well, of course it does, right? If I'm sitting here hurting, I'm not going to be in the greatest mood compared to as if I'm pain-free. Also think about, we get patients up and moving right away after some kind of surgery because I want to increase their mobility. I want to increase their healing. We know from evidence-based practice that the sooner people get up after a surgical procedure, the better outcomes they have in their healing process. So that's why we'll use pain medication, and then shortly thereafter start getting people moving, because we want them to be in as little pain as possible so they will move. So that's kind of the method to all of that. So barriers to an accurate pain assessment. It's important to use open-ended questions with the older adult, such as, tell me about your pain, aches, soreness, or discomfort. Again, especially with our older population, if we say, are you having any pain? Many, though they are, will tell us no, because they don't want to be looked at as having some kind of a problem or a burden, or that they're weak. And sometimes it is pride, and sometimes it's the whole, I don't want to bother the nurse. So we want to ask them. This is much like when we talk to our patients in an admission assessment, and this isn't just for Brighton, this is all places. We will ask them, how many alcoholic drinks do you have per day? We don't ask, do you drink? Do you smoke? How much do you smoke? Because we need to ask questions in a way that will elicit a response more than yes or no. So always remember that when we're doing pain, when you're doing alcoholic drinks, when you're doing smoking, all of those different things, try to avoid those closed-ended questions. The nurse can get much more information using this format versus do you have pain. So then you have your assessment tools here. You have the Wong-Baker faces, which you guys have all, I'm sure, have been exposed to and familiar with. The McGill Pain Questionnaire, this stuff is in your book. And then the pain assessment for advanced dementia. Okay, this is important. You want to know this stuff. 5 areas are evaluated for the patient who had advanced dementia and can no longer communicate verbally. So at the end, late stages of Alzheimer's as well. And so we look at these 5 different things. Their breathing, any negative vocalization, facial expressions, body language, and consolability. All right, so we're looking at how fast, how labored, how is their breathing pattern, or are they super short, tiny breaths because expansion of the lungs hurts? Negative vocalization, this would be like moaning or, making noises that are negative. Facial expression, are they grimacing? Do they have a grimace on their face, or are they squinting their eyes like something's hurting? Body language, are they curled up in a ball? Or are they guarding something? Are they guarding their arm? They don't want to be touched. And are they able to be consoled? I think of a baby with this, when a baby's crying and we just can't console them, and we're trying everything we can think of what's going on with this baby that's making it that it can't calm down, and same thing with our patients that can't tell us, are we able to console them or not? So healthcare concerns of the older adult, financial burden. This is a huge one. So you've got some information here that's pretty good. Healthcare expenses are 4 times higher than the general population for the older adult. Future estimates claim the average 65-year-old couple will need $215,000 to cover out-of-pocket expenses. So Medicare Part D, we're going to understand this. So Part D pays 75% of total drug costs after a $275 deductible up to the initial limit of $2510. Then there's this donut hole. From $2510 to $5726, there's nothing's covered. So it's almost like you don't want to use the Medicare Part D past 2510, or if you know you're going to go way past 2510, you want to get to the 5726. With that, there is other insurances though that patients can get to help cover that part, that donut hole that they call. That's like with the AARP stuff that you'll see the additional coverage. But once they hit the 5726 and above, Medicare Part D pays at 95%. So honestly, it doesn't make a lot of sense to me that it's set up that way. The caregiver burden, the amount of physical, emotional, financial, and psychosocial support provided to a loved one with a chronic illness. Those with chronic mental illness, that should say tend to not have caregivers. Because the person who is giving the care basically gets burned out. Ageism, this is defined as a bias against older people based on their advanced age. So this is like, I basically don't like that person because they're old. If I'm driving behind someone who's going extremely slow and I call them grandma, that's a part of ageism, because I'm automatically having this bias against this person driving slow because I believe that they're probably old. And then I pull up next to them and they're actually a 15-year-old that's in driver's training and driving with their mother. So, we have to be careful about that. There's ageism in public policy. You have 2 different associations. The Gray Panthers are one, and then the American Association of Retired Persons, that's AARP. And they do a lot at the legislative level for patients that are older age. And then ageism in research. Research can be difficult due to the reluctancy for people to participate. Healthcare decisions, advanced directives. Advanced directives are what tell a healthcare provider what the patient would want in the event they cannot make that decision. A living will is one. The statement is how and where one wishes to die. Only activated when the person is terminally ill and incapacitated. So it's a little bit different. Advanced directive provides the directions for everyone to follow and lists the preferences, whereas the living will just says how and where the person would like to die if they become terminally ill or incapacitated. May be altered any time if patient is competent. Directive to physician. This is a physician who's appointed to serve as a surrogate medical decision maker. Happens mostly when patient is terminal and has no family. Patient must be competent at the time of signing. And guardianship is a court-ordered guardian that acts on behalf of the individual. So the ANA, American Nurses Association, recommends that specific questions about advanced directive be part of every nurse's admission assessment. So that is mandated pretty much through any healthcare facility now. A psychiatric advanced directive, or is for those with serious mental illness, can designate a healthcare agent to make treatment decisions during an illness relapse. These are beneficial as those who have a relapsing condition do not typically have the insight to seek treatment. Okay, so that is it for that one. Again, if you guys have any questions or anything, I've opened up a Blackboard or a discussion in Blackboard for questions and that sort of thing. If you ask anything, I'll be back within probably that day. I'll check Blackboard every day. And you may want to use that instead of email, only because others may have that question as well. I guess that's it. See you guys later.